to CK. So step 2 CK, just general information, 8 60-minute blocks. That's a 9-hour exam total. That is a very long exam. And so part of getting ready for the exam is building your endurance and being ready to sit for 2-3 hours answering questions and staying focused for that time. Everything from step 1 is fair game in terms of information, plus the next best step. Part of the step 2 CK is testing your clinical knowledge. Do you know what the next best thing to do will be? Do you know what the best treatment is? Do you know what the best test is? And so that is where we need to start focusing our efforts in terms of studying. Resources. So I don't know what resources you have used so far. What I recommend is to have one big text for each subject. So when you're going through your clinical rotations, you had maybe an OBGYN book, you had your Step Up to Medicine book. These are your big texts. And if you've already been through that textbook, you've gotten what you need out of it, that's fine. Leave it behind you, with the exception of Step Up to Medicine. I recommend going through Step Up to Medicine while you're studying for Step 2 CK. We're going to talk in a few slides about how that all breaks down, but I do recommend holding on to that book for your dedicated time for Step 2 CK. Okay, so that's your big text. One comprehensive text. Now, this can be your first aid for Step 2. Not everyone liked it. That's what I used. Not everyone likes that particular text. There's also a Step Up to Step 2. I'm sure there are others. Master the Boards is another one. I don't really care. Whichever one you like. They all have different ways that they arrange the information. And so, what works for one person may not work for another. But you need to have one textbook that sort of has every subject in it and that you can constantly go back to and constantly annotate, just like you did with your first aid book for Step 1. You want to repeat that sort of strategy, okay? And so one big text, one comprehensive text. Obviously, UWorld is the key to success. You must have UWorld. I'm sure you do. And so we're definitely going to be heavily relying on that. And NBME exams. So the NBME exams that have been made available thanks to some friends on Facebook. There's a particular group on Facebook called the Ambience. Are you a member of that group? It's called the Ambience. I'll send you a link in an email after this session so that you can join it. And it has a lot of nice resources. But the best is just someone went through and took screenshots of every single NBME exam for Step 2. And so what you do is you go full screen with the images and you just go through the images one by one, answering them as you would on a regular NBME exam. And then when you're done, you look at those same images, but with the comments open, and you can see, number one, that there will be some consensus about what the right answer is. And then there will also be debate. And so I think that's very helpful because, you'll have some people saying, okay, this should be the right answer because of this, and then people discuss it and people debate it, and so I think you learn in that way too. So the Ambience is a very good group, and like I said, I'll send you a link so that you can join it as well, because NBME exams are going to be part of our strategy to assess where we're at during the exam or during our study period. Okay. So 3-phase approach. You mentioned that you're taking the Step 2 exam in January. Is that correct? Here with rapid review, we are just going to that comprehensive text, and we're going to review that as many times as possible, especially focusing on our weak areas over that next 3-week period. Okay? We're still doing UWorld here. Now we're increasing to 120 questions of UWorld a day. Okay? Phase 3 is our QBank. Here we're really just kind of crushing UWorld. We're doing as many questions per day. Here we're going to get up to 160 questions per day. 160 questions is 4 blocks. Okay? And if you can do those 4 blocks in one sitting, all the better. because guess what? This test, Step 2 CK, is a marathon. It is a slog. And so as you are preparing yourself to undergo this really intense exam, you need to be able to have this kind of endurance built up. Okay? And so during phase 3, getting ready for that exam, we're doing a lot of questions per day, 160. Okay? Now, throughout this time, sporadically, set some time aside to do those NBME exams. You should try and there's 4 of them, 4 NBMEs. And so, maybe do one soon, right? This week or next week. Do one after about a month. And then you have 2 more left over to do sort of whenever you want during that phase 3 time. Okay? Okay. Any questions about this sort of approach? Do you already have an approach, or does this help? Mm-hmm. Mm-hmm. Good. Good. Okay, so let's move forward. So this is really just sort of your daily schedule. System-wise, everything in phase 1. This is sort of, people have different thoughts about this. I like doing my UWorld and my rest of my studying together during my phase 1 because that's my knowledge acquisition phase. So I'm just trying to get as much as possible. So I would do my UWorld questions by system while doing my review of text by system, that same system, right? Then in phase 2 is when we start doing random UWorld questions. Okay, mix it up. That way it's more like what you're going to see on the exam. And then phase 3 is, we're really all about the questions, but for text review, it's just whenever you're missing questions, whatever is your lowest percentage in UWorld, that's what you should be rereading again and again and again, because the information is there, right? You copied it over if it wasn't there, and otherwise it's already in there. And so it's up to you to just keep going back to that text and rereading it and being really familiar. When you're looking at one page, imagine in your mind, what's the next page going to say, right? When you get to that point where you know what's on the next page, okay, you are ready for this exam, okay? That's a little extreme, I know, but that's sort of the goal that you should be working towards, is being really, really comfortable with that text and what it says, okay? So practice exams, importance cannot be overstated. It's a really good idea to sort of get in the rhythm, get your timings, utilize the Ambience NBMEs. Again, I'm going to send you the link after this. The UWorld self-assessments, they're helpful, they're difficult, they're not predictive at all. Okay, my UWorld self-assessment was 10 points off of what I got on my step 2. 10 points is a lot, right? So they're not predictive at all, but they are difficult, and so they will get you more in the right mindset. And whenever you're doing these, you want to act like it's the right thing. Put a timer on. Really make sure that when you're going back to review questions at the end of your block, that you're doing it within the prescribed time, okay? Because you want to have that feeling of, oh man, I really got to do this quick, so that you're really getting ready. Okay. Schedule. I don't know if you already booked your Step 2 CK. Did you already register and do all the paperwork through ECFMG, all that kind of stuff? Did you do that already? Yes? Good. Okay. So make sure you do that way in advance. Did you already get your date from the Prometric Center? Okay. Okay. Good. So make sure you do it at your school? Uh-huh. Uh-huh. I see. Okay, our school was something similar. Yeah. Okay, good. So as soon as they allow you to pick a date, do it right away, because I had a date that I wanted, and I thought I had plenty of time. I had maybe 8 weeks, and when I went to look, the closest date that was out was 10 weeks out. And so, okay, more time to study, but you have this idea of, okay, I want to do it like this, and when it doesn't come out that way, it's a little bit unnerving. So make sure that as soon as you can do that, go on the Prometric website and schedule it. Plan where you're going to party afterwards, right? You're working hard, you're doing all this, yes, to be a doctor, but also you need to be able to enjoy yourself a little bit after succeeding and taking your last licensing exam of medical school. Last licensing exam of medical school. That's huge. Okay. So you definitely need to reward yourself. Okay. So now we're going to talk about the good stuff, our approach to reading questions. Okay. So sure. Mm-hmm. Mm-hmm. No. And that was my mistake. You're not aiming to finish, to reset UWorld for Step 2 CK. It's not really necessary. I think going through it one time is enough. But in terms of hours per day, when I was studying, I did probably 4 hours in the morning, and then maybe 3 or 4 in the afternoon, depending on how the day went. But for me, my whole day was studying. Because I wanted to take the test quickly. My dedicated time only ended up being about 6 weeks. I had a very quick one, and so I wanted to do a lot per day. I think that 6 hours a day is sufficient, and so that's a sufficient time to review text and then also do 80 UWorld questions. That should be enough time. Okay. And so my strategy was in the morning. I would read my texts, because that's when I'm like the most focused. In the afternoon, I cannot just sit there reading. It's just too boring for me. And so I would do reading in the morning. And then in the afternoon is when I would do my UWorld questions. And I was very hard on myself when it came to UWorld questions. When I missed questions, I really, really wanted to know why I missed it. And I didn't want to miss that again. And that was for every single UWorld question. And I think that made me, it was like a self-motivation thing, right? When you're missing questions and you're hard on yourself, that's different than when you're missing questions and you're saying, oh, well, this is just UWorld. It's not going to be like that in the real thing, right? I think that you need to really kind of put the pressure on yourself and say, this is the only time I'm studying this stuff. This is the last time I have to study this stuff. I want to succeed, and I really want to do well, and I need to not be missing this stuff. Okay, so that's just sort of my quirk, my mindset. I want to not miss questions. So, but does that answer your question? I think about 6 hours a day as a minimum. Okay, great. Okay, so our approach to reading questions, the read the last line first thing. This we talk about since MCAT, right? Like this is a old rule of thumb. When you have these big paragraphs of text that they give you for your question, go straight to that last line. Where is the actual question? And then read the answer choices. That way you have some idea or roadmap of where you're going. Okay, so that's old advice. Everybody knows that. When you get those big texts, just go to that last line. If it's a 2-line question, you don't need to read the last line first. But if it's a big block of text, read that last line first. See what the question is actually asking you. You may not need to read that whole paragraph to get to the answer. Okay, so that's a classic one. But what's new for CK is this idea of building a differential. Because as a physician, like we're going advanced over nurses, PAs, and everything else because we have this ability to build a differential. And the test is testing your ability to do that. And so as you start to read the first few sentences, right, we're going to read that last line, and then we're going to go back to the top of the paragraph and read the first 2 sentences. You need to take about a 2-second pause and have a differential in your mind of what the possible conditions could be that is causing whatever the problem is. Okay, so you have someone who's presenting with shortness of breath, chest pain. What is my differential? Okay, before I'm going to read everything else to get me to the diagnosis, have that differential in mind. Okay, and it helps because when you are going through and reading the rest of that paragraph, and you already have your 3 choices of diseases that you think this can be, now as you're reading through, you can take that down to 2. You keep reading, you take that down to 1. Okay, and now when you get all the way to your answer choices, you have a very focused way of answering and arriving at the correct answer. Okay. What most people do, and I don't think it's helpful for CK, is that they will just read the whole paragraph and then have their best guess at the end of the paragraph and then go to the answer choices and then look back to the paragraph for each answer choice to see if it matches. Okay, that is doing double work. Now you're reading the paragraph twice. You're wasting time at that point. So this idea of building a differential, and it's a physical 2 seconds. So you read those first 2 seconds, first 2 sentences, and then you take 2 seconds and say, okay, I think this can be this, this, or this. It's going to take mental effort. It's going to take your ability to go back and say, what are all the possibilities? But this is what the test wants you to do. So let's look at a question. This is just a question that I wrote. This is no UWorld or anything like that. And we're gonna test this out. Okay. So first thing we do, we have a paragraph here. I don't want to read that whole thing first. I'm just going to look, what is the most likely diagnosis? I see HUS, ITP, TTP, Henoch-Schönlein-Purpura, so a bunch of blood stuff. Okay, great. So now I'm going to go back to the top of the stem. 58-year-old man presents for abnormal lab work showing microangiopathic hemolytic anemia. Okay, so now is where I take my 2 seconds. Okay, well, I know that my causes for MAHA is going to be my TTP, HUS. These are my major causes for microangiopathic hemolytic anemia. Okay, those are my 2. So now I have my differential. I'm going to go back to my question. His chart notes a recent episode of hematuria. Okay, well, that's common for both of them, right? We're going to have that damage to the kidneys in TTP and HUS, so that doesn't really help me. Physical exam, his vital signs, 130/95, 141, okay, a little tachycardic, a little bit elevated temperature, but no fever. He has a petechial rash on his abdomen. Okay, well, whenever we have low platelets, we're going to get a petechial rash, right? We have low platelets in TTP and HUS, so this doesn't really help me narrow it down either. Okay, going to keep going. Mental status is altered, and he does not appear to know where he is. Okay, well, I know from my studies that one of these conditions has a primarily neurological presentation. Okay, which one is that? Is it TTP or HUS? TTP, excellent. So now I can eliminate my HUS, go straight to my answer choices, select that, and keep it moving. Okay, now if we had not built our differential after this first sentence, we would have read through, gone to the most likely diagnosis, seen each HUS, and gone back and looked at our question stem and said, oh, do I see anything from HUS? Let me reread this. Oh, ITP, am I looking for anything in ITP? It's a waste of time to do it that way. Okay, and so the key here for every question, build that differential after the first 2 sentences. So as you move through, you are contributing to what your answer is going to be. All right, excellent. Now, this is step 2CK. They're not going to be asking you what's the most likely diagnosis in most of the cases. Instead, they're going to be asking you what is the next best step in treatment for this patient. Okay, and so this is the exact same question stem, but now we're kind of taking it to that next step. Okay, so with TTP, this is still TTP. What is the next best step in treatment? Well, what is the pathogenesis? What's happening in TTP? We're missing something, right? Or something's abnormal. Yes. This one, right? Adams TS13. Yes. Yes, good. So Adams TS13 is supposed to do what? Yes. No problem. That's okay. I'm putting you on the spot a little bit, I know, but this is kind of how it's gonna go. Unfortunately, with me as your tutor, I'm gonna continue to put you on the spot. So, Adams TS13. This is a metalloprotease or MMP. Okay, its job is to break other stuff down. Okay. And so Adams TS13, what its specific role to break down is von Willebrand factor multimers. So we have a bunch of von Willebrand factors stuck together. Okay, and this Adams TS13 is going to come in here and break down these connections between the multimers. Okay, if we lack Adams TS13, we have some sort of mutation, something happens with Adams TS13, then these von Willebrand factor multimers are going to stay connected. And when we have really big multimers, they end up being very sharp, almost like a shard of glass. Okay, imagine like a shard of glass moving through our bloodstream. It's going to be tearing up our red blood cells. It's going to be tearing up our platelets. It's going to be causing clotting. It's going to be causing, just a widespread, a lot of problems, damage to the endothelium, damage to the kidneys. And so this is our problem. We lose a metalloprotease and we end up with these large von Willebrand factor multimers. Okay, so with that in mind, the next best step in treatment, corticosteroids are not going to break up these multimers. I think we can agree on that, right? If we just give steroids, that's not going to do anything for these big shards of glass in our bloodstream. Okay, so this one we can take out. Furosemide, okay, we're already having kidney damage. Probably not a good idea to give Lasix. All right, plasmapheresis we're going to skip for now. Splenectomy, well, this is God bless you. Splenectomy. So this is a microangiopathic hemolytic anemia. Microangiopathic means capillaries, means we're not involving the spleen. Okay, so splenectomy will not help us here. Blood cultures and antibiotics. This is not HUS. This is not an infectious condition. So we're left here with plasmapheresis. Plasmapheresis will clear out all of our plasma, take out all of these big shards of glass, and kind of restore the normal balance. Okay. Now, our patient still has that risk of building up these von Willebrand factor multimers again. And so it's something we need to keep our eye on. But number one thing I want you to know, TTP treatment's going to be plasmapheresis. Okay, every time. All right. Now, let's say this patient's platelets are 50,000. Okay, normal platelets are what, 150 to 400, right? Let's say we look at this this gentleman's platelets and there's only 50. Okay, would you want to transfuse platelets? Do we need to transfuse platelets when we have 50? Awesome. Yes, we do not need to transfuse platelets. We don't transfuse at 30. We don't transfuse at 25. The only time we consider transfusion is when we get below 20. 20 is that cutoff point that you say, okay, now this patient's going to, be bleeding from every hole in their body. Let's go ahead and transfuse platelets. Okay? Great. Excellent. So this is going to be the way that we're going to look at questions. We're going to do a case review now, and as we do our case review, we're going to break down our questions kind of line by line so that we can apply our clinical thinking in the way that we need to do in the exam. Okay. Once we do a few of these cases and, I feel that you're comfortable with this idea of applying a differential, we're going to start just not going line by line, and I'm just going to give you the block of text, and then, you're going to start going through it just as a block of text. But we're going to kind of start slow, and you'll see what I mean. Okay, so case number 1. We have a 57-year-old man referred to a hematologist for detailed work of severe anemia. His hemoglobin level is 8.2. Okay. Yes. Yeah. Good. So all I was saying is just that as we are applying the ideas that I just sort of bequeathed to you, we're gonna, when we go through questions, go through cases, we're gonna go line by line like this. Okay. That way we can start to develop this skill of building a differential as we move through a question. Okay. But before we do this, did you have any questions on TTP or the previous question? Okay, great. So first case here, We have a 57-year-old man referred to a hematologist for detailed workup of severe anemia. Hemoglobin level comes out to 8.2. Okay, so what is on your mind? What is your differential? Mm-hmm. Good. Yep. Good. Good. I like that. Okay, so colon cancer, I wanted to make sure that you said colon cancer and iron deficiency. I wanted to make sure you said that. So what test would you want to do? Give me 2 tests to do right off the bat. Good. Good. Okay. 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 Excellent. Good. So we do that. Guac, no evidence of occult bleeding. Now we get a little bit more history here. So for the past several weeks, he's noticed blood on his toothbrush nearly every day. Complains that he bruises more easily than before. Okay. So now what are they describing here? What are they trying to tell you with this statement? Good. Okay, good. Definitely, I agree with you on the thrombocytopenia. And now we have a patient that has low red blood cells and thrombocytopenia. Okay, so 2 cell classes are low. All right, so now this is kind of pointing us in a different direction, right? Good. So he becomes increasingly fatigued, has cut back his hours on waste management because he often becomes short of breath with mild exertion. Okay, that can go with anemia. He complains that I always have a cold, I can't get rid of it. Okay, so having a cold a lot of the time is maybe telling us that we have a low number of what kind of cell? Mm-hmm. Good. In addition to low hemoglobin, we see a white blood cell count of 32,000, 3,200. Low retic count and a platelet count of 30,000. Peripheral smear shows myeloblast and markedly decreased granulocytes. Okay, so the next sentence could be a lot of different things, but most likely diagnosis. What are you thinking here? And excellent, yes. So you got the L. We just need 2 more letters. Okay, so we said that there's myeloblasts. Let's look at this next slide, actually. So here, this is showing us all the different cells that come from our pluripotent stem cells in our bone marrow. It can go on to become a lymphoid progenitor, giving us all of our white cells. It can go on to become a myeloid progenitor, giving us our red cells. Okay, so for myeloid progenitors, we have RBCs, megakaryocytes, which break down into platelets, mast cells, and then our myeloblasts. Okay, so this is the kind of cell that this guy's got. And myeloblast gives us our monocytes, basophils, eosinophils, neutrophils, all of these granulocytes, essentially is what they are, granulocytes. And so what they told us is that we have greater than 20% myeloblasts, right? Greater than 20%, that is abnormal. Greater than 20% myeloblasts, we're going to call this a myeloblastic leukemia. We're not going to make it complicated. Okay, this is a myeloblastic leukemia. And so the only thing we need to know is whether this is an acute myeloblastic leukemia or the chronic myeloblastic leukemia. And considering the sort of acute presentation of this is not a long asymptomatic course like in CML. A lot of times in CML, it's asymptomatic. It gets discovered on blood work. My aunt had CML. She had no idea. She had no symptoms except for a low heart rate. She went to see a hematologist and said, wow, you have CML. We need to start you on imatinib right now. And so CML has a very quiet, indolent course versus AML, which presents, as this gentleman did, anemia, thrombocytopenia, all these emias are typical of CML, right? Getting these infections because now we're using up all of our nutrients to make myeloid progenitors rather than our lymphoid progenitors. Okay, and so this is our AML. We're looking for someone who's an adult. Where's my pen? Hold on a second. So we're looking for someone who's an adult. What is the cause here? Some sort of translocation in the hematopoietic stem cell. Okay, so we lose our ability to produce red cells, granulocytes, platelets. Instead, these HSCs, hematopoietic stem cells, are all creating myeloblasts. Okay, those myeloblasts are just taking up the whole, all the nutrients, everything in the bone marrow. Okay, on a peripheral smear, we're going to see a myeloblast. Not the easiest thing to identify just with the naked eye, but I think the hour rod is something that we have sort of trained our eyes to look out for in these peripheral blood smears. Diagnosis: if you see greater than 20% myeloblasts, you should really be thinking myeloid leukemia. We're not going to make it any more complicated than it needs to be. Acute myeloid or myeloblastic leukemia is just lots of myeloblasts. Okay? And so, essentially we have this myeloblast proliferation. The hour rods we can see. In terms of flow cytometry, the CD34 should be present. And then our MPO for our myeloid markers. Okay? Great. Now, seeing these myeloblasts is sort of diagnostic for AML. Typically, those myeloblasts should never be in a peripheral smear. Myeloblasts should only be in the bone marrow. By the time the myeloblast differentiates into the neutrophil or basophil or whatever it's going to become, it's going to leave the bone marrow at that point. Okay, you should never see a myeloblast on the peripheral smear. So, quick high-yield points. Look for greater than 20% blasts in the peripheral smear. We're looking for myeloblasts. If you see that, pick your answer, keep it moving. There's only two ways to get greater than 20% blasts. Okay, so one is going to be our AML we just talked about. And two, during CML, we have something called a acute blast crisis, where all of a sudden the CML, instead of being indolent, it converts into this blast crisis where we start making all these myeloblasts. Okay, and so obviously the question is, how do we differentiate? Well, there's a certain type of translocation in CML, right? A certain type of chromosome, a Philadelphia chromosome. Good, 922. 922 translocation. So that's how we would be able to tell the difference. They would have to tell you something in the question stem about a 922 translocation. They would have to tell you your patient had a history of CML. Otherwise, it's going to be AML. Okay, AML until proven otherwise. How do we prove it otherwise? With that T922. Okay, wonderful. So patients, we're looking for those symptoms of anemia because we're losing our red cells. Our symptoms of thrombocytopenia, we're losing our platelets, and then minor infections of the skin due to the loss of those neutrophils, right? Neutrophils are very important in protecting the barriers in our body. And so if we lose our neutrophils, we're going to lose those barriers. Diagnosis, CBC, and bone marrow biopsy, and we're going to throw a peripheral blood smear in here as well. Okay, we want to see all those blasts on the PBS. Treatment here, anthracycline. Okay, you got me? Okay, good. So, I believe so. Okay. If not, well, hopefully you will. Hopefully you will. So, treatment, induction therapy with anthracyclines, cytarabine. Not terribly high yield. I don't think you need to memorize this particular point, but know that induction therapy would be our treatment here. If we are severely anemic, we can go ahead and transfuse our red cells. Bone marrow transplant should be curative here. Okay. Now, when we think about induction therapy, we're going to be destroying a lot of these cells that are granulocytes. What do we need to watch out for? Sure. So, what complications of induction therapy do we need to watch out for? And there's a few correct answers here. Whenever you start therapy, chemotherapy for your leukemias, what are some of the things that you look out for? Like a syndrome, a certain syndrome. Yes, exactly. Yes, I like where your mind is at. Yes, so it's the tumor lysis syndrome. From that cell turnover, essentially we're destroying a lot of cells. We're going to be releasing lots of potassium into our bloodstream, so we have those cardiac arrhythmias that we want to watch out for. Breakdown of all those nucleotides can lead to increased uric acid, so then we need to look out for gout. Okay, and when we talk about AML, and we have a lot of these myeloblasts with those hour rods, we're also going to keep an eye out for DIC. Okay? That's not all leukemias, but any leukemia that's involving these myeloblastic cells that have all of these really toxic granules inside, if we bust open these cells, release those granules, DIC is one thing that we want to be really careful about. We don't want to see that, okay? They already have low platelets, sort of a scary situation. Okay, great. Questions on AML? No? Okay, great. Let's move on to our case number 2 here. Great. So we have a 69-year-old man presents to the community clinic complaining of pain in his right thigh for the past 2 months. Reports fatigue for the past few weeks. Pain is constant, knife-like, and is always midway between his hip and knee. Does not radiate. Pain is 9 out of 10. Says he feels it deep in his bones. Okay? So, hit me with the differential. Just the first things that are popping into your mind, and then we'll keep it moving. Okay. Okay, good. Good. Yeah, so I'm glad you included multiple myeloma, I will say that. But everything you just named is really great things to have on your differential. And now we have an idea of where we want to go and what we're going to be looking for, what we need to eliminate to get to our answer. So this gentleman denies trauma to the area, femoral x-ray is negative for fracture, says he feels similar pain in the ribs, x-ray of the chest is negative for rib fractures. 3 months earlier, he had a severe bout of pneumonia, which was successfully treated. He has essential hypertension, for which he is taking hydrochlorothiazide. Quit smoking 20 years ago, but drinks a glass of brandy after dinner. Denies IV drug use. Okay, so now we're kind of eliminating maybe the abscess theory here. Relevant laboratory results are as follows. Hemoglobin's low. He's microcytic. Glucose is, a little on the high side. Sodium is normal. Potassium normal. Calcium, woof. Is that normal? Good. And you were 100% right. This is our multiple myeloma, aka plasma cell myeloma. Why do we call it plasma cell? Because it's a better name for it than multiple myeloma. Here, we're talking about the exact cell that's causing the problem. Okay? So, signs and symptoms of multiple myeloma. We're looking for usually elderly, usually African Americans, but it can really attack anyone. Our CRAB findings are very high yield here for establishing our disease. Hypercalcemia, renal failure. They didn't give us the renal failure, but that can be there. Anemia and lytic bone lesions. Okay. So abnormally produced serum IgG is what's, one of the reasons that we're having a problem here. And this can lead to infections. They talked about this gentleman's bout of pneumonia. Bence-Jones proteins in the kidneys. So these are light chains that you will find within the nephron that make their way, through the glomerulus, whatever, and get into the nephron. Okay, great. Morphology, we are looking for excess of plasma cells in the bone marrow. Okay. Other things we look for, right? We have this peripheral smear showing the rouleau formation. Because we have tons and tons of these IgGs, we end up with this formation of red blood cells. Great, that's step one stuff. Bone marrow with a very low number of plasma cells visible. But for this condition, we see a large number of plasma cells. Okay, great. Amyloid, because of all that extra protein, we can end up with amyloid. All right, and we see our lytic bone lesions here and our gamma globulin spike. Right, this is all kind of step one type stuff, but God bless you. Just a review of the important stuff we need to know. So, high yield points, those crab findings are key, but you're always going to have anemia. Okay, that is sort of the most central part of this condition. You always see anemia. But on top of that, bone pain, osteoporosis, right? You nailed it from the first line of this question, so that was really good. We can look at for renal failure, susceptible to infection, especially encapsulated bugs. We're not making the appropriate immunoglobulins. Instead, we're making the same immunoglobulin over and over and over. So we're not able to respond to bugs that require immunoglobulins to be treated. Okay. Plasma cells are the pathogenesis here. They stimulate osteoclasts, giving us our bone breakdown, interfere with red blood cell synthesis. Our diagnosis, bone marrow biopsy and that plasma electrophoresis showing our gamma globulin spike. There is no known cure for multiple myeloma. Essentially, all we can do is do induction therapy to decrease that number of plasma cells and sort of treat the symptoms at the same time. The induction therapy that is used here is thalidomide and dexamethasone. So we have one basically antibiotic, and then we have one corticosterone, okay? Or glucocorticoid, excuse me. Other symptoms we need to treat as well. So keep an eye out if the hypercalcemia gets too high. We need to keep an eye out for that. Fractures we'll need to treat, and renal failure, okay? All right, so as a bonus, in what patient population is thalidomide contraindicated? Well, this one, so yeah, I would agree with that. We would not want to give it if someone already has a low number of B cells and T cells. But for this specific patient population, the contraindication, we're looking for pregnant women. Okay. Yes, the tiny limbs, good, yeah. Yeah, the word that they use, it's like a Latin word, which means seal limbs, which I think is kind of rude, but yeah, so correct, yep, that's why. Very good. Any questions on multiple myeloma? Okay. Daphne, are you okay with this format of going through cases like this, talking about the idea behind it? I know before you said you didn't really want to lecture, but I think it's helpful to kind of go through these ideas as we do the questions. But I'm open to sort of changing things around if you'd like. Hello? Can you hear me? Okay, great. Okay, good. So we'll keep doing it this way through our sessions together. I think it's helpful too. This is okay. Welcome back. You didn't miss anything. Okay, so we're going to our case number 3 here. 21-year-old woman presents to her PCP with pain and swelling of right lower leg. Uh-oh. Yes, please. Okay. Okay. You know what? The first couple things that come to your mind, then keep it moving, because we don't want to spend a long time when we're doing 270 questions all day. You don't want to spend a long time with every single differential, right? So first few things that pop in your mind and keep it moving. You're just like, not only is this helping you with the question, but it's helping you focus, which is sort of the ulterior benefit here. Okay, so DVT and cellulitis, I like it. Pain began the night before following a 12-hour plane flight. Did not improve with resting overnight. Denies fevers or trauma to the leg. Only medication is OCP. When questioned, she mentions that multiple family members have suffered similar symptoms. Okay. And maternal grandmother died of a pulmonary embolism. Okay. And so is anything kind of creeping up in your mind as a potential cause here? Mm-hmm. Okay, awesome. Good. So a physical examination, normal. Lower leg, erythematous without a palpable cord, but she has that increased pain with dorsiflexion of the right foot. And so, yes, so you nailed the diagnosis. You're exactly right. So factor V Lieden, but just sort of as a review of our step 1 stuff, 3 things that promote thrombosis are Virchow's triangle, endothelial injury, hypercoagulability, and abnormal blood flow. Our young lady has this one. This idea of provoked or unprovoked, what would you say, is her DVT provoked or unprovoked? Exactly. So this would be a provoked DVT. Great. So what this is, the reason that I left that in is because when it comes to all of these hypercoagulability syndromes, there's kind of grades to them. So we have a young lady here who has 2 risk factors for having a DVT. She's on OCPs, right? And she had this long plane flight and she ended up with a DVT. Now, if this was someone, much older, we would say, okay, maybe we're not too suspicious about an underlying syndrome, but someone so young with this provoked DVT, we can consider an underlying syndrome. However, other inherited hypercoagulability syndromes, you can have unprovoked DVTs and pulmonary embolisms, okay? And so in terms of what else may be contributing to the hypercoagulable state, you already nailed it. It's factor V Lieden. Yes, excellent. What other inheritable conditions are there? We'll kind of talk about that as we go through. So factor V Lieden, this is a mutation in factor V, making it resistant to inactivation, okay? This is our most common of genetic hypercoagulable states, and so in a question like the one we just did, that would always be the correct answer if they didn't give you any extra information, okay? Because it's the most common. 2 to 15% of white people have it. Pathogenesis, factor V is resistant to inactivation by activated protein C. Activated protein C. Protein C and protein S are our anticoagulation proteins synthesized by the liver, right? And so when we activate protein C, it's going to go and find that factor V, it's going to find factor 2, it's going to find factor 7, and it's going to find factor 9. It's going to find those 4, break them down, okay? So that is the idea there. Factor V Lieden is less severe than inherited mutations in protein C and protein S. And so this is what I was referring to earlier. If we instead had a patient who had an unprovoked DVT, very young, with that family history, I wouldn't want you to pick factor V Lieden. Even though it's more common, for an unprovoked DVT, it would be more likely to be one of the more severe ones. Okay? Activated protein C can deactivate factor Va at 2 different sites. That's sort of the idea of why factor V Lieden is less severe, because protein C is still able to do its job. It just takes a lot longer. Okay? We're looking for a normal PTT and PT, which makes sense. Diagnosis here. So we're going to do coag studies. The idea of coag studies is that we take a patient plasma and control plasma. We add APC to try and prolong that APTT in the control plasma, but in the patient plasma, we're not going to be able to prolong that APTT because it's resistant to APC. I think that makes sense, okay? And then we can confirm it via genetic testing, looking for that arginine, glutamine translation, I guess is what that would be. So we've replaced an arginine with a glutamine. Okay. Great. So high yield points, just sort of repeating everything from before. We're looking for DVT-PE, central retinal vein occlusion. That's sort of one of those low key ones that might not make you think of it right away. But in the retinal vein, when you occlude that vein, you end up with a lot of blood kind of collecting in the back of the eye and the retina. It's called blood and thunder is the way it's described. It's very... it really sticks out in your mind if you ever Google a picture of CRVO and look at what it looks like. It's like, whoa, that's incredible. And so that's sort of one of the things that trigger ophthalmologists to look for these inherited hypercoagulable states. Coag studies, confirmation. So to treat these patients, if they're actively thrombosing, we're going to do what we would do for any other person with a thrombus. We're going to start them on heparin and then move to warfarin. Okay? Now, we don't want to leave these patients on warfarin because warfarin works by decreasing the levels of coag proteins made by the liver. Okay? Now, the coag proteins made by the liver include protein C. Okay? And so if we are reducing our levels of protein C in a patient that's already resistant to protein C, what's going to happen? They're going to clot again, and it'll usually be right after you start warfarin. Okay? This is what we call our warfarin skin necrosis. Right? So we don't want to leave them on warfarin. We can break up that clot, and then we're just going to cut warfarin off because we don't want to risk that. Okay? If we have an increased risk of thrombus anticipated, such as someone who's planning on getting pregnant, okay, we want to give them low molecular weight heparin to prevent those thrombi. However, we know that patients with this disease have a high risk of miscarriages, unfortunately. Okay, and OCPs in general should be avoided. Okay, great. Questions on factor V, Lieden? Okay, well, let's lead our way on. Oh, we have one more question here. What else on a differential for our patient with hypercoagulable state? So we said protein C and S deficiency. What else? What else should go on a differential? What else can make a hypercoagulable state in a patient like this? That's okay. So just cancer in general. Cancer in general. Cancer promotes a coagulable state. There's something called antiphospholipid syndrome. Okay. And I think that's pretty much all I had for you. Yep. So factor V lead in protein C and protein S, cancer, antiphospholipid syndrome. That is our hypercoagulable state. Usual suspects. So those are the ones we'll keep in mind and want to test for. Okay. Great. So I think we can do, I have it all written here. And antithrombin deficiency. So our patient with a nephrotic syndrome where they are losing all of that antithrombin 3 through the glomerulus, through the nephron, they lose that. They have antithrombin deficiency, and that can sort of predispose. Okay? Yes. Excellent. For the antiphospholipid syndrome, right? Yeah. Yeah. So for nephrotic syndrome, there is a membranous nephropathy that is associated with SLE. That's correct. But there's also our minimal change disease, right? There's also, our... Sorry, go ahead. Oh, the crescentic. Good. Yes. That was the word that triggered it for me. So for crescentic glomerulonephritis, that is our rapidly progressive glomerulonephritis, and that is more common in patients with Goodpasture syndrome, okay, or our MPO So that one and our Wegener's. Those patients get the crescentic. That is sort of the end game of a lot of those conditions where your kidney failure is imminent. Okay, for our antithrombin deficiency, you can really just have that loss of the negative charge on your basement membrane. right? And that's what's allowing the antithrombin to move through, and you end up deficient in that. You lose your albumin, you lose immunoglobulins. All these proteins are just leaving out of the kidney in nephrotic syndrome. Okay, great. Yeah, no problem. Do you have time for one more case? I know we kind of got started. We've had these interruptions, but it's 8 o'clock now. If you have time for one more case, we'll do one more. Awesome. Okay. So here we have a 4-year-old girl presents to her pediatrician with a 2-week history of cough, nasal congestion, and fatigue. Okay. So what pops to your mind? Okay. Sure. Okay. Good. HSP or virus. I like it. Okay. I'm glad that you said virus. I was getting a little concerned. Good. Yes. Kawasaki, HSP, virus. I love it. Let's keep going. Her mother has brought her in 3 times in the past month for unremitting cold symptoms. Each time the child's been diagnosed with a viral upper respiratory tract infection. Advised on symptomatic care. She's been sleeping more usual over the past few days. Awoke this morning with a new rash. Physical examination. She has a temperature of 37.2 and a pulse of 140. Is this tachycardic in her age group? Not very tachycardic. I think the upper limit you'll see is either 120 or 130. Okay? But she's a little bit tachycardic. For babies, for newborns, that's normal. Excellent. Good. All right. So pale, scatter petechiae across the lower legs, hepatosplenomegaly, cervical lymphadenopathy. Okay? And so here, just kind of breaking this down, we have multiple infections, so we're thinking low white blood cell count. Tachycardia and pallor. Okay, so that means a low red blood cell count. The petechiae, of course, is a low platelet count. So we sort of have multiple of these cell lines that are decreased. Hepatosplenomegaly plus lymphadenopathy. You can't really think about anything else but leukemia at that point, right? When you have a swollen liver and swollen spleen plus lymph nodes, you have to think leukemia. So this is our acute lymphoblastic leukemia. Okay. This is really, your leukemia of children. 80% of all cases are children. Patients with Down syndrome have a higher risk of developing ALL, right? If they're over 5, if they're under 5, it tends to be more AML. In terms of translocations, we're looking for a 12-21 when we're talking about children. Adults can get ALL. If they do, they have the Philadelphia chromosome, and it's a whole nother story. And it's really much less common. I just left that in there for the sake of completeness. But what I want you to memorize from ALL, this B-cell ALL in children, is that 12-21 translocation. Okay. We have these markers. Great. T-cell ALL is T for kind of teenagers. These kids are usually a little bit older to have a T-cell ALL. All right, and we're looking for T-cell markers. CD3 is a classic T-cell marker. These are also TDT positive, and most common presentation is a mediastinal mass. Okay, so if they gave us the exact same patient over again, a little bit older, and with a mediastinal mass, maybe giving them shortness of breath, compressing that airway, you would choose T-cell ALL. Okay, it's T for teenager, T for thymus, T for T-cell. Okay, we're going to include all that in there. Okay, and unlike AML, ALL actually can infiltrate the CNS and testes. So that is something that they will test you on to make sure that you know. All right. Here, because it's a lymphoblast, not our myeloblasts, like we talked about before, it's a totally different cell line, right? And so we're not going to see granules. We're not going to see our rods. We're just going to see these, large cells, scant cytoplasm, big nuclei. That's what we look for on that peripheral blood smear. Okay. Our flow cytometry is always helpful, looking for all those markers. And chemotherapy actually is a very good treatment for this particular condition. We can have an 85% cure rate. Okay? So favorable factors, I don't find it helpful to memorize the favorable. I usually just memorize the unfavorable. So CNS testicular involvement, that is a negative prognosticator. Okay, greater than 10 years old at diagnosis, white blood cell count over 50,000. That's a lot. And one of these translocations, the 922 Philadelphia chromosome or the 411 translocation, happen to be unfavorable. Okay. Great. So, yep. They would have basically swollen, but they shouldn't be painless. They should be painless. Should be painless, yes. Swelling of the testicles. Okay. Good question. All right, so, there's multiple cytopenias. We're looking for greater than 25% lymphoblasts. Okay, remember on our AML, we want greater than 20% myeloblasts. ALL, 25% lymphoblasts. Okay, talked about our negative prognosticators. Before induction, we're going to hydrate the patient. We're going to start them on, this was the thing I meant to ask you earlier, and I totally forgot. What is the drug we can give for tumor lysis syndrome to prevent it? Allopurinol is going to prevent that hyperuricemia and the renal sufficiency. Okay, so that is very helpful. Okay, so our bonus question here. ALL can present with a white blood cell count over 100K, often resulting in a condition called leukostasis. What are some of the symptoms and pathology of leukostasis? Okay, so just thinking about this idea of having a white blood cell count over 100,000. Okay, this is a lot of white blood cells. Just thousands and thousands of white blood cells, essentially clogging up our capillaries. Just sort of, I want you to imagine polycythemia, except all white blood cells. This is what's happening. Okay, except in polycythemia, you have cells that can carry oxygen, right? Here, we're looking at cells that cannot carry oxygen. So we're going to look for signs of ischemia. We're going to look for neuro changes. We're going to look for chest pain, myocardial ischemia, et cetera, et cetera. Essentially, you're just having a lot of obstruction of all of your small capillaries. Okay? So that is leukostasis. Definitely fair game for your exam. Okay? All right, great. Any other questions on ALL or anything else that I can help with? Yeah. Okay. Well, Dr. Bennett, was great meeting you today. Tomorrow we will continue with our hematology and talking about all these fun cancers. And please let me know. I'm going to email you after we finish and send you a link to that group so that you can join it. Please let